today's episode of Myeloma Crowd Radio, a show that connects myeloma patients with researchers. I'm your host, Jenny Ahlstrom, and we'd like to thank our episode sponsor, Bristol Myers Squibb, for their support of this program. We would like to wish everybody happy holidays. We've just completed one of the busiest times of the year with the American Society of Hematology, or the ASH meeting. And this is a once-a-year event where global experts in hematology get together to discuss recent findings and their discoveries and their papers. And you'll notice on the myelomacrowd.org website, we have a lot of that content. And we'll continue through the rest of December and likely through January because there was a lot of information there. So please check out those ASH articles and stay up to date on the incredible progress being made in the multiple myeloma space. We are very excited to have a show talking about COVID-related things and also other studies that are expanding things to the myeloma community and really trying to understand what's the impact of COVID on multiple myeloma and precursor conditions in patients, but also how do we prevent myeloma from happening in the first place? And for that, we have Dr. Irene Ghobrial of the Dana-Farber Cancer Institute with us today. So welcome, Dr. Ghobrial.
Thank you, Jenny, and happy holidays to everyone. And thanks again for having me on your radio show.
Oh, sure. Let me introduce you before we get started, and then we'll just launch in with our questions. Dr. Ghobrial received her medical degree from Cairo University School of Medicine in Egypt, and she's an attending physician in medical oncology at the Dana-Farber Cancer Institute. She is professor of medicine at the Harvard Medical School. She's director of the Clinical Investigator Research Program at Dana-Farber and director of the Michelle and Stephen Kirsch Laboratory. Dr. Ghobrial is a physician-scientist who specializes in the field of multiple myeloma and Waldenström's and does a significant amount of work on precursor conditions like monoclonal gammopathy of undetermined significance, or MGUS, and smoldering myeloma. She focuses on the role of how these precursor conditions progress to active myeloma and is very intent on shutting that down before it becomes active myeloma. She created the Center for Prevention of Progression of Blood Cancers, where patients with these precursor conditions can be monitored for different evolution to see why they progress and how. And that is something that we'll talk about that today in today's show. But that's a study that patients can join but don't need to travel. And she is the lead primary investigator for these PCROWD and PROMISE studies, and the PROMISE study, which has been significantly funded by Stand Up to Cancer. So it's a very important award that she received for that. She's now launching this impact study. So Dr. Ghobrial, maybe you want to explain what you've learned so far from the PCROWD and the PROMISE studies, and we can go into more detail about what those studies are a little bit when you talk about who's eligible to join the impact study. But what have we learned so far from your prior work, and then share more about the impact study?
Yeah, absolutely. So maybe I'll start with PCROWD first and then move to PROMISE and then move to the new study, impact.
Okay.
PCROWD started a few years ago, and the whole idea was we have a lot of databases and we had a lot of information about myeloma, but we don't about precursors, about MGUS, monoclonal gammopathy of undetermined significance, and smoldering myeloma. And what we hope to do is, if we can understand better who will truly progress in their lifetime to myeloma, if you have MGUS or if you have smoldering myeloma, instead of doing the watch and wait, or as people say, watch and worry, why don't we understand together as a community what causes progression, genetics, epigenetics, immune system, and then once we know that, we can develop better biomarkers. We can tell you in a more predictive way if you will progress in your lifetime or not, and that can help you make a better decision. Do I need to be treated early or not? And the hope is we truly prevent progression. We never have anyone wait until they develop myeloma and then we treat them. We never wait for you to have fractures, bone lesions, anemia, renal failure. We always treat you earlier to prevent all of these end organ damage, or damage basically of your organs. And the hope was that instead of having you come to Dana-Farber or come to one of us in big cancer centers, why don't we bring it to you? So this is a truly patient-empowered, direct-to-patient access nationwide and actually now internationally, where you click online to log in to pcrowd.org, And then you can enter your information and you become part of the study. You consent online. You don't need a physician. You don't need anyone. And whenever you're going, and basically we send you a kit for your blood or for your bone marrow biopsy, and we ask you, are you okay that we ask your doctor to give us your clinical data, your information? And actually, HealthTree now that Jenny is doing is wonderful because it can give us access also to that clinical information, or gives you access to that clinical information. And as we do that, we get thousands of people who serially give us their blood or bone marrow sample. And then when you have 2,000, 3,000 people who have precursor conditions, now we can ask the big questions. Now we have enough numbers to say, okay, now we can understand who progresses. And actually, when we launched that 4 or 5 years ago, we had 3,000 people. We are serially following them. We hope to get actually more and more. The hope is we get up to 10,000 and more so that we can understand it better. And we already have shown several new studies within the last year that made an impact already for our community to understand mechanisms of progression. So we know that if we sequence, we do something called next generation sequencing, and we look at your own sample from the bone marrow or from the blood, what we call liquid biopsy, we can define certain markers that can predict for us who will progress from smoldering myeloma to active disease, and potentially use those markers to be even more predictive than clinical markers to tell us who should be treated early. We're hoping to bring that into the clinic immediately so that we can order that test and we can help you immediately. For now, it's research level only, but I'm hoping within 2021, this will be one of the initiatives we want to bring. We also learned that your immune system, even at the MGUS stage, is not normal completely, and you may be prone to certain infections, and we'll come back to that with the COVID-19 in a second. But we did something called single cell sequencing, where we look at all of the single cells at each individual cell from your immune system, and we found that indeed even at the MGUS stage, not only at myeloma, your immune system is not completely normal, and then it starts getting worse as we go to myeloma. And that helps us also develop therapies. We can develop immunotherapy early on and so on. So that was PCROWD, and it's precursor crowdsourcing. We're crowdsourcing for patients, basically, and telling you, this is your community, please help us. And I would encourage everyone who's listening now, if you have MGUS, if you have smoldering myeloma, please sign up. We would love to have everyone on it. Now, a few years ago, 2 years ago, we applied to Stand Up to Cancer to say, well, something doesn't make sense. Why are we waiting for people to develop myeloma? Why are we not screening for it? We know that cancer screening saves lives. And we know that breast cancer screening with mammography, colon cancer screening with colonoscopy makes a huge difference. Why can't we just get a blood test, a simple blood test, and look for myeloma, which is the protein level, the monoclonal spike that we call it? So we launched a study to look in high-risk individuals. So this is not for everyone. This is for people who are at very high risk of developing myeloma. We will look for their monoclonal protein, but instead of doing it by the usual serum protein electrophoresis, we're doing it by a more sensitive test called mass spectrometry, which was developed recently by Binding Site in collaboration with Mayo Clinic. And we give you that result back for free. So this is the PROMISE study. And again, while people are looking at that, please log on onto promisestudy.org. And what we said is we will screen 30,000 individuals. So this is a big study nationwide again. They are either family members of people who have a blood cancer, so your own sister, brother, mom, dad, and kids over the age of 40 to age 75. If you have a blood cancer, so if you have myeloma or a precursor like MGUS or smoldering or any blood cancer, lymphoma, leukemia, you are eligible, or your family members are eligible, and they can sign up. And we send them a kit, and they go to Quest Diagnostic, any Quest Diagnostic nationwide, and they get that blood draw. Part of it will go to Mayo Clinic, where we get the results. So this is the clinical result, whether you have a monoclonal protein or not, and we call you with the information, and we help you. If you do have MGUS, we work through the system. We actually see you virtually. We now have this to offer for you a virtual clinic or a telemedicine clinic with me or with any members at Dana-Farber, or we refer you to someone else if there is someone local. We want to make sure that if you are diagnosed with this, we provide the best care possible. We call it white glove care for anyone who goes on PROMISE. And then if you're negative, we rescreen you back again in 3 years. So that's the PROMISE study. Now, of course, when COVID started, March of this year, we said, well, we have no idea how COVID will affect our patients with MGUS or smoldering, and especially that PROMISE study is trying to recruit people who are Black Americans. So actually the other recruitment part, the other high-risk individual is if you are Black or if you are of African descent, you have a 2 to 3 times higher chance of developing myeloma, and we still don't know why. So for PROMISE, you're either a family member or you are Black or of African descent. So we said, well, we don't know if COVID will affect you worse or not. If you have a precursor condition, we know that your immune system is not normal, but you're not all the way to myeloma, and people may not know that you're truly at risk. And now that we have the vaccines rolling in, we don't know if you will respond as well as a normal person, if your immune system will give you that sustained immunity against COVID once you get the vaccine. So we said, well, why don't we launch a study called IMPACT, and it's theimpactstudy.org. Again, you can look it up right now while we're speaking. And anyone who signed up to PCROWD or anyone who signed up to PROMISE, you can also sign up to IMPACT. And now we can draw your blood, tell you if you have a COVID-19 antibody test. So that's through Quest Diagnostic. They're doing it for free for us. So we'll give you your results. You get to know if you had the infection or not, which is important. And then when you get vaccination or when we follow you for the next year, we will ask you to give us samples every 3 months for 1 year so that we can see how does your immune system look like after getting the vaccine. Or if you got infected, what does your immune system look like at 3 months, at 6 months? So we're doing all of these single-cell sequencing of your immune system in your blood. We're also looking for inflammation, cytokines. We're looking for CHIP mutations, which is certain mutations that can predispose people to have a worse infection. And we're hoping to do that and release the information immediately back to you. So everyone who's on the portal will be available, that data will be available immediately for them every 3 months as we sequence the samples. So that's the IMPACT study. And we know that it's hard, especially now with COVID. So we said people who are signing up for the first time for PROMISE, they get 2 in 1. They can sign up for PROMISE and get IMPACT, and we also can give them a $50 gift card because they're, spending the time and effort to compensate for their time and for going to Quest Diagnostics. So they get both kits in one for PROMISE and IMPACT at the same time.
Okay, that makes a lot of sense. If they get the kit and they're already going to their facility, can they draw it there and then they mail it off, or you have to do it through Quest?
So for the COVID antibody test, because it's a Quest Diagnostic test, they have to go to a Quest Diagnostic.
Yeah.
So that's why it's important to go there. And if it's PROMISE, because the kit has to go to Mayo Clinic and it has to be drawn by a certain phlebotomist, it also has to be to Quest. If they don't have a Quest Diagnostic local or near them, we can send them a phlebotomist at home. There is a service that we can send them at home, a phlebotomist.
So either way, it'll be just convenient to your local area, and you don't really have to travel anywhere. I think Quest has a lot of facilities that you can find in your community. Is there a major website that you can go look at to find where your closest facility would be?
Yes, there is. Yeah, absolutely. There is a link. So once you put in your area code or your your address, it actually would tell you where is a local facility.
Oh, okay.
We're also trying to see if we can even work with pharmacies and Walmart and anything else. Quest is also in Walmart right now. So we're trying to make it as easy for you as possible. But again, let us know if you have any problems. We are always happy to help and try to send a phlebotomist at home.
I've done that before, to just get labs run, gone to just a local Quest Diagnostics without having to go to my facility, and it's really simple. So usually there aren't that many people in there, and they take your blood and you're done. It's very, very fast.
Well, thank you, Jen,
good.
for giving that. It's important to know that feedback. That's wonderful.
Yeah, it was easy when I did it. We have so much to learn about COVID, I think. And I'm sure you've had COVID-positive myeloma patients now. Is there anything you want to share about what you've learned? Because what you mentioned before is really important. We don't know how myeloma patients are going to respond to the vaccine. I think everyone's very excited that there is a vaccine now available and starting to be rolled out. I would imagine that you as a healthcare worker will probably be one of the first to get it, but also myeloma patients might be some of the first to get it. So that's just, there's so much we don't know yet about that, I think Dr. Rajay was mentioning that as well, like, will myeloma patients, just because they are already immunocompromised, will they have the same type of responses? Will they have durable antibodies? Like, how will they react? So what's been your experience so far, I guess, in your clinic with COVID-positive myeloma patients and then those with precursor conditions?
Yeah, absolutely. So we've had, of course, like many others, a few cases of patients with myeloma who are on therapy, who had also COVID, and many of them were hospitalized. I had one of my patients who was in the intensive care unit for a long time, and he recovered wonderfully. Another patient, she actually received the Regeneron antibody, so we were very lucky that that was recent, and it was on clinical trials. Again, you've seen some of the publications that some of the patients with myeloma did not do well, but that was early on in the early setting when we didn't have access to many new drugs. I think now we still should be very careful. We still should be cautious with everything. But hopefully, as we get the vaccine, as we get to understand better the immune system and the response of the immune system to COVID, we can give you more advice. And I would say that's why we're doing the impact studies, to truly understand what is the response of the immune system to COVID, not only the infection, but also the vaccine in our own patients, and give you back that information. So instead of giving you a hypothesis, maybe they will respond well or not, I can actually give you data in a few months from now.
And I'm glad that you're doing the blood-based test. I think Dana asked this question in a prior show with Dr. Richter, and he noted that she was asking which type of blood test is actually the best to determine if you have COVID, also to determine if you have the antibodies, and he was noting that it was the blood test. So how does this test that you're running at Quest compare to the other tests we might be more familiar with for antibody testing or COVID test? Does it test to see if you have it and if you've developed antibodies, or what does the test actually do?
Yeah, so that's an important question. There are two different types of tests. There are some that are to see if you have currently the active infection. These are usually PCR-based, not antibody-based. So this just says the virus is there and I can detect the virus. And these can be, of course, from the nasal swab or from the saliva or from tissues and so on, or blood, of course. That's not what we're doing in the impact study. That's very important if you think you have the infection currently, you should be tested, of course. The antibody test asks the question, did you get infected in the past? And that could be in the recent past or in the long, several months ago, because there are different types of antibodies, IgM or IgG. And that's the one that we're testing right now in the blood. And we chose Quest Diagnostic because we had a relationship with them and because they have an FDA-approved test, and their data shows that it's a very sensitive and specific test. At the same time, we have here at Dana-Farber a much more sensitive test, but it's research level only, so it's 10 times or 20 times more sensitive than the ones being out there as FDA-approved ones. But it's research level, and we can run 1,000 samples per day. And we will be doing that in collaboration with one of our doctors here, Eric Fisher, who developed that new test on all of the samples. So as a research level, we will also be repeating it again with all the different types of antibodies here.
Okay, great. That's amazing. And so essentially in this impact study, you're going to have a group with precursor conditions from the PCROWD study, so MGUS or smoldering myeloma patients. And then you'll also have kind of this control group or non-myeloma related group from the PROMISE study, and then you'll be able to compare the two really well. I mean, I think that's a really neat study design because you'll have both. People who are impacted already.
You're right, and they're almost all of the same age. They were at risk of developing myeloma, but they don't have it. Like we said in PROMISE, we're hoping to have 20% Black Americans, so we can ask the question, why is race playing a part in this? So absolutely, we're going to be asking a lot of big questions, not only of COVID, but also in general of our immune system in many of our patient population or population at risk.
Yeah, and I think you could also look at things like, I think in COVID you're looking at things like diabetes or heart conditions or other things that might make you more vulnerable to COVID or having worse outcomes if you get COVID. But some of those same things are present in some precursor condition patients, and it might give you the opportunity to look at these, what they call, comorbidities or other diseases that might be adjacent to the precursor condition or not, and just see, is there a difference? Like, you might be able to identify something truly unique in comparing these two precursor condition groups and what you call a normal population as you're going to look at this. So it might not just be how we're going to respond to the COVID vaccine, but it might be even something deeper than that.
Yeah, absolutely, Jenny. We should collaborate on all the research together, because you're right. This is going to be beyond COVID. We're collecting samples for circulating free DNA, for circulating tumor cells, for metabolomics, proteomics. We're keeping it wide open to ask big questions in the long run too, and not only the specific question that's currently important, which is the COVID-19 question.
Right, and I think that's an important question. So when it comes to things like the flu vaccine, I know sometimes the doctors will say you definitely get the flu vaccine this year, but you might need to get booster shots because myeloma patients have more depressed immune systems or things like that. When you think about this COVID-19 vaccine, I think everybody's curious, like, will it help me develop antibodies if I'm immunosuppressed? And then will I need booster type shots? And I guess over time, because you're watching patients, at 3 months, 6 months, and 1 year, you're going to be able to see trends and patterns. How do you I guess, do you have any ideas or hypotheses now before you start the study? I'm sure you'll have more later as you have other people, more people participate. But what would be your guess, I guess, if you had to guess about this? I mean, everything's so new, I guess. That's a hard question for me to ask.
Well, yeah, I mean, it's hard to guess, and sometimes we go in with one hypothesis, and that's the best part of research, that we are surprised that we are not correct. And we have to be very open-minded in saying the research will tell us the answer and not what we want to say as the answer. I really don't know. I'm hoping that we will mount a good enough immune system that lasts for a long time, but maybe that will not be true. Maybe MGUS will mount a certain immune system almost as healthy control, but maybe not. Maybe smoldering myeloma, maybe it's a stage-wise as you get more progressive in myeloma, from MGUS to smoldering to active disease, you have less and less of an immune response. I might be wrong about that, but we don't know until we get to answer those questions and have the longitudinal samples every 3 months for 1 year to really see what will happen. Do we need booster vaccines, like you said? Do we need serial vaccines every year? Do we need 2 shots more than anyone else, right? So there are lots of questions there that we need to understand better.
We've had a lot of patients ask, like, if they're immunosuppressed, should they be taking IVIG? How do you see IVIG relating to any of this? Like, especially do precursor condition patients need IVIG ever? Do they use that? I'm not very familiar with if they do or don't.
Yeah. So IVIG is basically you're giving back your own immunoglobulin G to people who have a very low level of immunoglobulin G. And that happens when your normal immunoglobulins are suppressed because either you have the myeloma and it's secreting bad non-functional antibodies, immunoglobulins, or because you've been on therapy and dexamethasone or daratumumab or Velcade or any of the therapies kill the plasma cells. And by doing that, you're killing also the good normal plasma cells that make antibodies. So we usually know that people who have a low immunoglobulin, especially immunoglobulin G, may be prone to recurrent infections, pneumonia, sinus infections, and so on. And by giving you IVIG, we're trying to help you get some of that protective effect from someone else's immunoglobulins. Now, those will not protect you from COVID-19 because we do not have prior antibodies to COVID-19 because this is a new virus, so no one has been previously exposed to it. So currently, IVIG that you get right now will not be protective to you for COVID-19, and that's why the studies that are ongoing right now are using convalescent plasma, which is plasma from people who recovered from COVID-19, and giving it back to them to see if that can help. That will be something hopefully available in the future as more and more people have COVID antibodies. For smoldering myeloma and for some MGUS patients, their immunoglobulins may also be suppressed, what we call immunoparesis, and that just means that already their plasma cells, the good normal plasma cells, are suppressed, and that's a sign that the bad plasma cells are already acting up. And it's one of the bad prognostic markers of progression from smoldering myeloma to active myeloma in one of the studies, like the Spanish studies that have been done. We sometimes give IVIG, but usually not. If you don't have recurrent infections in smoldering myeloma, we wouldn't, say that you need IVIG in those patients.
Mm-hmm. And just a question about this COVID vaccine as it comes out. Are you recommending that all your patients get it, and even precursor patients, MGUS and smoldering myeloma patients?
Yes, absolutely. We hope that everyone should get it. I don't know when we will have the rollout for every patient. This is something that we're waiting to get answers at Dana-Farber, but I hope that everyone, I encourage everyone to get it.
Mm-hmm. And in the small amount of patients that you've seen that have gotten it, do they develop strong antibodies, and do those antibodies last? You probably don't have enough information, right? Not enough patients to determine that yet, because it's probably a very small number of patients, right?
Yeah. So far
I'm
it
just
has
curious.
been rolled out to. Yeah, I wish we had the answer. We all want to have that answer. And so far, since approval, it has been approved to healthcare workers, and I guess the first vaccinations were, 2 days ago? And then we will start giving it to patients, and then we will start seeing the effects. And we don't have data, of course, on the clinical trials, whether they had certain number of patients who were immunocompromised or not. They have not released that data, and who was on placebo and who was on the vaccine. So I think this coming year, and that's why the impact study is so, timely, we will get all of those answers, hopefully within the next 3-6 months and so on.
Right. Well, we'll have to do another program so you can share what you've learned from the study.
Absolutely.
Well, earlier in the show, you mentioned that we know that the patients with precursor conditions like MGUS and smoldering myeloma have immune system changes. Do you want to share what you've learned, what you mean by that? And then I'd like to also just kind of review again, like if you're participating in one of the other studies, anyway, I'll ask that question after we talk about this. So do you just kind of want to share what immune system changes you see happening earlier at these different stages, these precursor stages?
Yeah, absolutely. So we did a paper, and I'm happy to share the paper. Anyone who wants it, it's in Nature Cancer in this year, 2020, where we did something called single-cell sequencing of the bone marrow cells from healthy people, MGUS, smoldering, and multiple myeloma. And we're hoping to expand this beyond what we've done so far. And what was interesting is I thought that we will have different levels where from normal to MGUS, you'll have a little bit of a change, but not much, because MGUS might look like a benign, normal thing, and you might have a normal immune system, and then it starts getting worse. But we were surprised that actually some of the MGUS bone marrow immune cells looked exactly like myeloma, that it was this sudden change from healthy to MGUS, your immune system is already changing. And that was interesting because I did not expect MGUS to be that abnormal in the immune system. And then you do see further changes, further progressive changes in the NK cells and the T cells as you go to smoldering myeloma and then to active disease. But there was this one jump from normal to MGUS that definitely affected it. And I think that's critical for us. And I don't mean to scare anyone who has MGUS, because maybe those changes are not in any way going to affect your progression or going to affect your response to infections. But I see it in many of my patients who tell me I get recurrent infections, or I have autoimmune diseases, or I have something weird. And you go, we never thought of it. Or when we think of vaccinations in our patients with MGUS, we have to start thinking, will they really mount a good response to vaccine if their immune system is not working well? You can also start thinking, should I think of immunotherapy, of activating T cells and NK cells as early as smoldering myeloma as a way to prevent myeloma progression? If we know there is something already altered, can we harness the immune system to improve it before it goes to active myeloma? And that's what we're doing in some of the clinical trials that we're launching in 2021, is we're bringing in bispecific antibodies and other immunotherapies like NK cell early on in the smoldering setting.
Well, I think that's such an important idea, because if you can shut it down and boost your immune system to be able to fight it, you may never progress, and that's been your goal for many years, to shut down that progression. So that's amazing. I think this is so important, though, in the context of COVID, because one of the reasons I'm asking that is if you do have MGUS and you are seeing these early changes, then we really need to know, like, how does COVID affect you, and how does it affect you over the long term with a different, quote, different immune system that you have as not only just a myeloma patient, but as a precursor condition patient. And that's what you're trying to learn in this impact study.
Yeah, I mean, you're right. It's not just that how MGUS or smoldering affects your COVID response, but also how COVID affects you and affects your immune system and your inflammation environment. And will that make you progress faster or slower to myeloma?
Yeah, that would be a little alarming. So I think it's what you said before. Patients should still take whatever precautions they can and try not to get it. I think we're all so tired of COVID.
We are.
Sometimes it's easy to just go, okay, never mind. But you really still have to stay vigilant, even though you don't want to. And especially during holidays, it's hard, but it's important. So if you can help me review, like let's say somebody has not yet participated in the PCROWD study, or they haven't joined the PROMISE study yet, or their family members haven't joined, or if you're African American, you haven't joined yet. But you want to join those studies, and then can you just walk me through the logistics again of how the kits would be mailed to you? Because you can decide to join PCROWD or the PROMISE study right now, right? It's not just for people who are already in it, but you can join those two studies and join the impact study at the same time, correct?
Correct. Yes, absolutely. And that's what we're encouraging. We're telling everyone, if you have MGUS or smoldering myeloma, sign up to PCROWD anytime. It's P and then CROWD. You can look it up. It's PCROWD.org. And you can look up Dana Farber at PCROWD or my name and PCROWD, and you'll find the link. And again, if you have any problems, please email us anytime. PROMISE is for anyone who is a relative. So if you have MGUS or smoldering or myeloma or any blood cancer, lymphoma, leukemia, your first-degree relative is eligible. So while you're in the holidays and you're talking to family, encourage them to look for it. Cancer screening can make a huge difference. I personally signed up for PROMISE because I'm of African origin. I'm from Egypt. And I would highly encourage everyone to sign up for it, because why wouldn't you want to know early what could potentially be preventable? And that's what I hope in the future all of us can do, a blood test to know if we have early cancers and we can prevent them. In fact, this is what we're hoping to do in general, not only for myeloma, but all the other cancers. If I can detect it early and I can prevent it, I hope in the future I never develop an active cancer. And again, yes, it could be a little bit, scary to know, but I'd rather know than wait 2, 3 years, 4 years from now and have back pain and then get diagnosed with myeloma. So if you are of African origin, or if you're Black, and if you have a first-degree relative of any blood cancer, you can go on promisestudy.org, sign up. And once you sign up, it's very simple. It takes 5 minutes to sign up. Then you can also sign up to the impact study, so the impactstudy.org, and the same kit, it's basically 2-in-1. The same kit can be used. We mail it to you. You can then get an appointment at Quest, and they're very good. They're very organized. You don't have to go in and stand in line. You can just get an appointment. You go get your blood drawn, and that's it. You get to know if you have MGUS or smoldering myeloma, and we call you and we help you, or if you're negative, it's a good thing to know. And we also tell you if you had the COVID-19 antibody test or not, and we're also doing the $50 gift card to everyone who goes for PROMISE. For PCROWD, you don't need to go to Quest Diagnostic because you're already an established patient with an oncologist already. So whenever you're going next time to your doctor, just take the kit with you and have them draw it for you whenever they're drawing your blood count as usual. And then again, use and go to Quest Diagnostic at that time.
Okay, so that makes sense. I think sometimes it needs reviewing because sometimes it can be confusing for patients to know, like, what do I take with me, or where do I need to go and when? But I think the important thing that you're learning from the PCROWD study is that what you said earlier, you have had thousands of patients participate now, and you do know you're learning important things from those studies. And those are both blood samples and bone marrow samples, right? So if you're already going to your doctor's office, you can, like you just said, invite them to do just. Mm-hmm. Yeah,
either blood, or if you're doing a bone marrow biopsy, of course, we will ask you to give us some of your bone marrow. And I think it's important for everyone to know that your blood sample, which is easy and simple, can give us a lot of information, as much as your bone marrow sometimes. So it's important to give us that blood sample too.
Mm-hmm. Well, with the more detailed blood testing that you're doing, I think like using mass spectrometry instead of the regular test, for the monoclonal or the SPEP, I guess it's called, that gives you more information.
Absolutely. It's a much more sensitive test. And for the first time, we're using it for screening in this PROMISE study. And in fact, we were expecting to have only 3 to 5% of the population to be positive when we screen them. We found that we are up to 10% screen positive. That's a very high number of those high-risk individuals we are screening. So that tells us that we are actually targeting the right population if we're getting 10% positive rate.
And I know you worked a lot with Dr. Kyle. And do you want to just go over a little bit of some of the history there with MGUS? Because if this is true and 10% of the population that you're screening has MGUS, then there's a lot we don't know, right? About these precursor conditions and what we can and can't do. And like I was looking at some of the ASH data that was, you kind of referred to a little bit earlier in the show, but that said, like, I mean, there's some certain groups, certain groups have these early mutations in these precursor conditions, and then some don't have that many, and you're kind of separating them into two different groups.
Yes. So let's talk about Bob Kyle, because he's truly the grandfather of multiple myeloma and a pioneer. Bob Kyle, and he's 95, I think now, and still leads many of the studies. He actually coined the name monoclonal gammopathy of undetermined significance, MGUS, as well as the name smoldering myeloma. So he's truly the one who made all of those discoveries. And it's wonderful because I trained with him at Mayo Clinic, and I always look up to him as my, guiding physician who has really made everything possible for us. And hopefully we would move on with his research to understand it better and better. But he came up with the idea that there are indeed people who have this monoclonal protein, the M spike, but they don't have myeloma. And Jan Waldenstrom, who's another physician who was wonderful, he's the one who actually described the disease, Waldenstrom macroglobulinemia, told him, well, this is likely just a benign thing, that's not cancer, and let's not worry about it. And Bob Kyle was smart enough to say, well, what if they can develop myeloma in the future? What if this is a precursor to myeloma and it's not just a benign condition? Let's not ignore it. Let's follow those patients. And he actually started the first screening study in Olmsted County, Minnesota, which is very close to Mayo Clinic. He sent a letter to all of the people who live in that county and said, do you mind giving me your blood draw? And I will see if you have this M spike. So it's exactly like PROMISE, but done 50 years ago. And indeed, he found that 3% of the population over the age of 50, if you just screen them randomly, you will find 3% of the people have this MGUS. And the rate of progression to myeloma is 1% per year. So every year you only have a 1% chance and 99% chance of having nothing. So you may have already a change in your cells. You have this precancerous cell, but it doesn't go all the way to myeloma. And now we're trying to understand why and what happens. And that happens in many other cancers. All the time as we get older, many of our cells can change, can mutate, and become abnormal. In fact, as we get older, there is something called CHIP mutations, stem cell mutations that happen in our own blood stem cells. And again, 3% of the population over the age of 50 may have those CHIP clonal hematopoiesis of indeterminate potential, and that in the future can go on to develop MDS or leukemia. And we now actually are finding correlation or work that can make and myeloma come together and happen together. So we're all getting older with mutations happening in our cells. The question is, can we detect them early so that we can prevent them from going all the way to leukemia or myeloma? Can we understand who developed them and why would you develop them? Why would I develop MGUS or CHIP while my brother does not or my sister does not? Or why a certain family has such a strong family history? Why do Black Americans have 2 to 3 times higher chance of developing myeloma compared to Caucasians? What's so high in that? So there must be some also underlying germline. We are born with certain DNA or epigenetic changes that predispose us to getting those. And all of those factors plus other factors like the environment, exposure to pesticides, obesity, so many other factors can contribute into the rate of progression. And if we can understand them better, we can, one, give you better markers so that we can be more precise in why you developed it, but also when will you have problems from it. And we can also prevent it in the future. Maybe we can develop a vaccine for MGUS, just like we developed a vaccine for COVID, and we prevent MGUS from going on to myeloma for everyone. And that's truly not, something that can happen in 20, 30, 40 years. It can actually happen within the next 5 to 10 years if we work hard on understanding it and developing it.
Well, yes, you and Dr. Ghobrial have done so much work on this. And, that name, monoclonal gammopathy of undetermined significance, I guess the question would be, what research obstacles do we have to overcome to get a monoclonal gammopathy of determined significance, I mean, You're working on that, right? But
Exactly. We should have that name changed.
And what do you see as those key barriers? I mean, you've talked about some of it, and it's just having enough data, right?
Correct. And that's why I would love to have, this is truly researched by the community, by everyone. We cannot do that on our own. We cannot do it in cell lines or mouse models. This is truly work by the patients for the patients. And we cannot get it unless we have large cohorts to ask those big questions. Because if we do it on only 100, 200 patients, it's not powered enough to answer the big question. So I would truly encourage everyone. It's a blood sample. If you want to really give back to the research community, help us understand what causes myeloma in many of us. Help us understand what causes progression from MGUS to smoldering. If you have myeloma, encourage your family members, because by understanding why they are at risk, if they are your first-degree relatives, we can then understand what causes myeloma in the first place.
So I think a perfect Christmas present to ask your family, if you are a myeloma patient, to give you is to participate in the PROMISE study. I think that's a perfect gift to ask them. They don't have to buy you anything. They just have to sign up and go to Quest. So
I totally agree.
that will be the Christmas present that I ask for from my sisters. My parents they don't qualify because they're over the age range, but my sisters are available to do that. And it's truly, like you're saying, this group effort. And if we really want to come to conclusions faster, we need to invite our families to contribute and our friends to contribute. And sometimes they are willing to take us to appointments and sit with us in the infusion clinic. But I think it's just an easy ask to say, and I'll go with you too, if you want me to. Then we'll go to lunch afterwards and make it a family affair. But this is something that we can do as families, and even during the holidays. We could do it during the holidays to do this together. So I just think it's really important.
Absolutely. I totally agree with you. And I think it is, like you said, it is a gift to help us understand, to help yourself and your family understand who's at risk and why, and define things that we can do in our own hands rather than wait for it to happen is such an important gift for all of us. And thank you for encouraging your sisters and your family to participate.
Yeah, I think it's absolutely critical. Do you want to review while we have a few minutes, do you want to review any important things? You did it at the beginning a little bit with ASH, but I think there's so much happening in the precursor condition space that I think it would be helpful if you pointed out important things. And I also want to note that you participated on one of our myeloma crowd roundtables and reviewed a lot about MGUS and smoldering myeloma. So we'll include a link to that in the transcript for this show. But I think that'd be helpful, and then we'll open it up for some caller questions.
Absolutely. I think ASH this year had sort of two themes in the MGUS and smoldering area, but we can also talk about regular myeloma therapies. One was, again, trying to define who will progress from smoldering myeloma to active disease. What is this high-risk smoldering? And many of you already know the clinical marker, something called 20-20, which is 20% plasma cells, 2 gram M spike, 20 light chain ratio. And all of us said that's good, but not good enough, because it's a one-time point, while a patient is not one-time point. A patient has, continuous numbers, and a 20% plasma cell number is not so accurate. You can have a bone marrow biopsy, and on one side it's 10%. If I do it again on another side, it will be 30%. So did you suddenly change in your own prognosis? And the answer is no. Those numbers that we use may not be the most accurate numbers. So we're trying to change it into more of a continuous variable, something that every time you come in, we adjust the prognostic markers. We can change and be smarter in how we can prognosticate things so that we can give you more accuracy in your decision. And that was done by something called circulating tumor cells by the Spanish group. We had done it by the genomic markers. As I said, we have identified 3 markers that can predict progression, and we're hoping to add to them more. The other thing that is important is understanding therapy. Should I be treated if I have high-risk smoldering myeloma? And I think there were 2 studies that we know of, done of Revlimid or lenalidomide versus nothing, and then the ECOG study. And these are good, but again, being careful that we don't overtreat or undertreat. And what I mean is, if you have really high-risk smoldering myeloma, I would rather treat you like real myeloma than treat you only with lenalidomide, because it may be under-treating you, and that may not be good. And then the vice versa, if you are high-risk smoldering by 20-20, but you really don't have bad markers, maybe lenalidomide is not a good idea for you either.
Yeah, because it wouldn't, you don't know. Like if I knew I was going to progress with high-risk smoldering myeloma to active myeloma and it's coming, then I wouldn't even do a doublet probably, like Revlimid and Dex. I'm not sure how that would help me a whole lot. I would probably want to just jump into full myeloma treatment, and that idea that your longest remission is going to be your first remission, you might want to do something more like the ASCENT study or something like that.
Yeah, so what we're hoping to do is something called precision interception. Not every patient has the same disease. We should not be treating you the same way. And what we hope to do is, if you have 11-14, we put you on venetoclax. If you have a P53, 17P, something bad, we put you on a bispecific, something more aggressive. If you have something mild, or if you have almost myeloma, you can go to ASCENT, or we're opening soon daratumumab RVD, like the Griffin study. So we're bringing active myeloma therapy early. If you have, in the future, we will think of if you have KRAS mutation, BRAF mutation, we put you on those. So again, come to us and talk to us. And again, this is, I think Jenny really brings it to the point of have a second opinion, because not only myeloma is subspecialized, smoldering myeloma is even more subspecialized, and you need to really talk to people who do it for a living and can give you a second opinion. And we're happy to see you. We launched PPOP as in all virtual. You don't have to come to Dana-Farber to see us. You can get a second opinion without stepping out of your own house.
I think that's fantastic. And I know you've done telemedicine. I've referred patients to you before who you've done telemedicine visits for. And what a blessing. And that to me is a gift. And I know a lot of good things haven't happened out of COVID, but that's one thing that has happened that has been helpful for patients who are older and immunocompromised and don't really want to get on a plane all the time to join studies like this and get second opinions without having to travel. And thank you for doing that, because that's a gift to us as patients. It's true. It's very hard, that knowing what to do, and especially in the smoldering myeloma space, you're like, is it time? Is it time? Like patients who are relapsing, and I personally understand the psychology around that. It's tough to know, what do I do and when do I do it, and I feel like I'm playing chess with my life. It's hard. So I just am so grateful that for you and for people like you who are willing to specialize and really help us as patients know what to do and know what all the options are. So thank you.
No, absolutely. And thank you, Jenny. And I agree with you. There is one blessing that came from COVID-19 is for us to innovate, for us to change the way we practice medicine. And I agree that telemedicine or virtual visits hopefully are here to stay, where you don't have to travel all the way to Boston to get a second opinion.
Yeah, it would be worth going, but it's much better if you don't have to fly, if you don't need to.
That's
okay,
true,
well,
especially that we have a winter storm coming up.
Yeah. Yes. Well, I would like to open it up for caller questions. So if you have a question for Dr. Ghobrial, you can call 347-637-2631. You can push 1 on your keypad, and I'm sure she'd be happy to answer questions around precursor conditions, the studies, or COVID as well. So we'll start with caller at 990-1090. Go ahead with your question.
Thank you, Dr. Ghobrial. The HealthTree profiles have a robust amount of information in them. Is there any way that you can access using existing HealthTree profiles, or are there any additional questions or things that could be added to HealthTree to benefit the studies that you're doing?
Yeah, it's a great question. And in fact, Jenny and I were just talking about a collaboration between our studies together, that anyone who's on HealthTree who wants to sign up to PCROWD or PROMISE, or vice versa, anyone who's on PROMISE and PCROWD can sign up to HealthTree. In general, we have a epidemiological questionnaire that we ask patients. It includes not only, your family history, do you have strong family history of cancers or not, smoking and all of those things, but it also includes certain questions of diet and nutrition and exposure. And then we ask you to give us a consent to get your medical records from your doctors because we want to double check MSPICs and bone marrow biopsies and cytogenetics. I think the HealthTree is innovative in that. And I think one of the things we can do is really work together with HealthTree to have this database available, as well as also what we're building available for HealthTree so that everyone can access their data on an app on their phone. That's truly what we're hoping for, is that you can just open your app, see your numbers, but also be able to communicate with us. And it gives you reminders of when is your next blood draw. It gives you more information. We're also going to hopefully work soon with a company called Vibrant Health. They're the ones who actually are doing All of Us, which is this big study from the NIH. And we're hoping that we will also launch wearables where you can wear a Fitbit or your Apple Watch, and it will give us more information about your health and fitness and exercise, and can potentially push out clinical trials to people, like an exercise trial or a intermittent fasting trial, things that are easy that you don't have to come to see us to get access to those. So the future of using whether it's HealthTree or whether wearables or whether it's information on your phone is here to come, and we're hoping to use that. And again, if you guys have any ideas, please send it to us. This is really, an area where we ask people to give us advice and help.
Thank you.
Yeah, that's great. Okay, thanks so much. Okay, caller at 734-2790. Go ahead with your question.
Oh, hi. Thank you for Thank you for taking the call. I have a question to the doctor there, and thank you for taking the call. A few days ago, Imperial College in London announced that they have, and there's a press release which I can send you, the team has developed a new drug which they're rolling out in 6 universities for testing that selectively kills myeloma cells in the bone marrow without impacting healthy tissue. In the past, the research has been focused on the NF-kB pathway. The team from Imperial College took a different approach. They've kind of effectively got by that issue. They've developed a new drug, and it's called DTP3, which kills the myeloma cells and, importantly, lacks a toxic effect on healthy cells. So far, it's been established that this has the same cancer-killing efficiency as Velcade, a drug that you're probably familiar with. However, DP3 is 100 times more selective. As they're rolling it out, the clinical evidence so far shows that it selectively kills myeloma cells in bone marrow. So of course, I'm not a scientist or a doctor, but my question to you is, first of all, could you get yourself enjoined to that rollout and test this if you think it's worthwhile? They're rolling it out to 6 universities after Imperial College announced it. If you wish, I can show you I can send you the press release, and I'm sure you're familiar with Imperial College. So could you just comment on that?
Yeah, so we're definitely open to any new ideas and any new clinical trials. Usually we wait for seeing safety in phase 1 and phase 2 in active myeloma, and then we try to bring it earlier in the smoldering setting. But we're definitely open to all innovative ideas and all new drug development, and not just what's available right now.
Yeah, and that
Would
one
you
will
like
look
to
good. Oh, I can
send you the press
send it.
release.
Yeah. Okay, I can send it to her too, because we just wrote an article on that actually yesterday. So yeah,
Okay,
that looks interesting.
And I know
thanks
some
a lot.
volunteers would be happy to sign up.
Okay, sounds great. Thanks.
Thank you very
Good
much.
question. Oops, I'm so sorry. Okay, we have caller 3641388. Go ahead with your question.
Yes. Hi. Hello. Thank you. I have MGUS, and I'm reading something about the vaccine having to do with spike protein, and I wanted to know if there's a risk in taking the vaccine because I already have a spike in my blood protein.
Yeah, that's a great question. Different spikes, but they're both spikes, I guess. So a spike protein is basically the protein on the surface of the virus, and that's completely different than the monoclonal spike, which is basically your antibody, the immunoglobulins that you secrete from the plasma cells of MGUS or smoldering. And when we run it on a gel, they all show up in one area, and we call this the monoclonal spike, or the area where all the monoclonal proteins show up. Completely different spikes, unrelated to each other at all.
Okay, great. Thank you so much.
Okay, thanks. Great question. Okay, caller at 534-8191. Go ahead with your question.
Hi, Dr. Ghobrial. Thank you for all that you do in this field. I have smoldering myeloma. I'm a part of the PCROWD study, and I've also signed up for the IMPACT study. My question is on the IMPACT study. I'm a little confused. Once we've had the initial blood draw and we know if we've tested negative or positive for COVID, does everyone continue on for the next, 3 months, 6 months, 12 months, or just people that have tested positive?
Yeah, it's a great question, and thank you so much for your contribution on PCROWD and IMPACT. Originally, we had said we would only follow up the positive cohort, but we're actually amending the protocol, so you will be getting an email soon in the next week or so to ask you to continue and get the 3 months, 6 months, 9 months samples, because we noticed that even if you're negative, we may want to capture the data of your vaccination. We may want to capture the data of what if you get infected between now and a year from now. So we don't want to lose that information. So we will ask you again, if you're willing, to continue to give us samples even if you're negative.
And I signed up maybe a week and a half, 2 weeks ago. How long is it taking to get the initial kit out to people?
Yeah, so that's a great question. We are trying to time it out so that not everyone is getting. We had a wonderful response. We had 280 people sign up within the first 10 days. And because my lab cannot process all of the samples safely at the same time, we're trying to time it that we get 40, 50 samples back. So you'll find us actually not sending kits on time. And the only reason is that we're trying to time it out so that not everyone is sending us back the samples. And then we have 200 kits at the same time. We try to process everything, and the technicians are working day and night on this.
And one final assurance, it's all right for those of us in the study to just go ahead and get a vaccine when it's available, correct?
Absolutely. And what we will do in that new amendment, so when you sign up again on Impact, is we will ask you, we're adding a questionnaire about the vaccine because all of this is changing as we change. So the trial was approved. Our Impact study was approved before even vaccination was available. Now that it's available, we're adding a questionnaire to say, if you're receiving the vaccine, can you give us the date so that we know the immune response, how it is linked to the date of vaccination. So you will find a few amendments, which means people will sign up again and get a consent again. Hopefully it will be very simple for us to ask you, when did you get the vaccine, give us the date, and then if you can continue on giving us blood samples.
All right. Thank you so much. I'm looking forward to being a part of it.
Thank you again for those questions and for the clarification.
Thank you.
And thanks for joining the studies. That's so wonderful. Dr. Ghobrial, thank you so much for sharing this important study with everybody. I think it will help us understand just so many things. So on the precursor status, but on COVID status, really for everybody, not just these precursor patients, just for everyone. So I would encourage everyone to please consider joining both these PCROWD and the PROMISE studies. Invite your family members, ask them to do it as a Christmas gift for you. And it's just so important. So I also want to remind everybody that this Saturday we are having a roundtable online interactive webcast on side effect solutions. So if you have the side effects, that we'll have 2 key myeloma specialists participating on that, and you can look forward to that. But Dr. Ghobrial, thank you so much for participating today and for sharing your important work.
Absolutely. Thank you, Jenny, for having me, and thank you, everyone, for listening in.
Okay, and thanks to our listeners for listening to Myeloma Crowd Radio. We invite you to tune in next time to learn more about the latest in myeloma research and what it means for you.
Lucky Land Casino, asking people, what's the weirdest place you've gotten lucky?
Lucky? In line at the deli, I guess?
Aha, in my dentist's office. More than once, actually.
Do I have to say?
Yes, you do.
In the car before my kids' PTA meeting.
Really?
Yes.
Excuse me, what's the weirdest place you've gotten lucky?
I never win and tell.
Well, there you have it. You can get lucky anywhere, playing at LuckyLandSlots.com. Play for free right now. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18+. Terms and conditions apply. See website for details.